Okay, last week we talked about some HCCs and other Medicare reimbursement models. This week we're going to take a look at the reimbursement from the hospital side. So let's have a look. Okay, so this is dealing with Medicare Hospital Acute Inpatient Payment System. This will get into MSDRGs, case mix, and all these other new terms that you will see in your text. And again, anytime we have changes to Medicare in terms of either HCCs or the hospital setting, they're put in the Federal Register. And this diagram gives you a quick summary of how we get into the final rule. And these things are adjusted for a variety of reasons: cost, different technologies, and others. When we look at cost, one of the reasons we have to adjust cost is that CMS, the Centers for Medicare and Medicaid Services, has to get data, and this data is provided from the hospital. So this includes data from hospitals, skilled nursing facilities, renal dialysis centers, home health, health clinics, anybody who's getting CMS funding. And the data includes such things as facility characteristics, cost and charges, Medicare settlement data, financial statement data. And this kind of goes back to something we touched on earlier, the value-based purchasing. And the idea is that CMS is the largest payer of healthcare services in the world, wants to pay for quality care that involves better care for individuals, better health for the population, and lowering costs through improvements. And so again, they have the quality strategy that is also in your text. And again, some of the things that we covered just on the other slide. We want to make healthcare more affordable, safer, and higher quality. We don't want to just throw money out the window at things that are ineffective and don't work. So there's three components to this that you can see over here. The CMS value-based purchasing program is linking quality to reimbursement in that we are paying for reporting, paying for performance, and paying for value. With the quality reporting program, we pay for the reporting program that's included in most Medicare payment systems. In other words, you have to submit data to CMS and then you get payment. CMS allows facilities to maintain full payment if they successfully participate in the program. If they're not so successful, they will be financially penalized, and we'll take a look at that in Table 5.1 in your text. And you can see here's an example of it. If you don't meet the terms under these laws, you will be penalized as follows: 1/4 of the applicable annual payment rate update, 2% of the reduction to OPPS conversion factor, and so on. So as you can see, CMS is not playing around when they want to have facilities provide quality care. Also of note, this extends not just to acute care facilities, also covers long-term care, inpatient rehabilitation, hospice, home health, and others. When we have acute care inpatient services, we're looking at a few different things with the IPPS, the Inpatient Prospective Payment System. We're looking at a case rate reimbursement methodology, and we're looking at primarily when we think health information, we're thinking acute care facilities. And there's certain things that are carved out and under a somewhat different payment model, such as psychiatry, mental health hospitals, rehabilitation, long-term care. When we're also looking at certain dedicated cancer centers, these are inpatient payments, prospective payments exempt, and the reimbursed versus the reasonable cost. And this runs on a rate year, in other words, a federal fiscal year of October 1st through September 30th of the following year. And what happens with this, we have Medicare severity diagnosis related groups, and these are groupings of diseases. And in the trade, we refer to these as MSDRGs. And basically, we're grouping inpatient admissions into larger groups. And the idea is that we pay on a capitated basis based on similar cases. And that involves relative weight, which is the resource intensity of each category, the case mix, in other words, how complex the patient population is to take care of, and the case mix index, which is the weighted average of the sum of all the relative weights of all the patients during a specific time period. MSDRGs allow the measurement of the hospital's case mix complexity. So this is an indicator of how resource intensive the hospital is. So a hospital with a more complex case mix by right should consume more resources than a hospital that has a less complex case mix. And again, in contrast to HCCs, where you can have multiple HCCs and the reimbursement is cumulative, with MSDRGs, we can only have one MSDRG per hospital admission, or as it says here, per encounter. And this covers the facility costs for everything. These are medications, supplies, inpatient nursing, tests, everything. And the facility will, if they can treat the patient for less, they keep it and make a profit. However, if they don't manage their patients effectively and they incur more costs than the reimbursement for these admissions, they will lose money. And you hear people referring to these as MSDRG winners and losers. I'm going to stop at this slide, but basically the MDC, the major disease category, is 25 categories split, and these are split into MSDRGs that are surgical and medical. And then we get into finer deviations of this. And that's all I have for you. Come back for the next video lecture, and we will discuss more about MSDRGs and inpatient hospital reimbursement.